Thanks, Rod, and thanks for the kind invitation to talk about one of my favourite subjects, particularly at the moment, RSV, because we can finally do something about it. And I think as a paediatrician who's been working for over 30 years in children's hospitals, every winter is harbinged by the arrival of RSV, sick kids, sick staff sometimes, particularly the junior staff exposed for the first time, and the hospital's full and people stay in ED because there's no beds available. And there's a similar increase in activity occurring in general practice with these children. So to have potential interventions in the next 12 months is a fantastic effort. So, and I've never thought about having a fan club, but we'll have to see. I'd first like to acknowledge that we are all on Wajak Noongar Budja, and I'd pay my respects to elders past, present, and their emerging leaders and any Aboriginal people and Torres Strait Islander people who are in this room today. I want to sort of make the point that we need to particularly make sure that with these interventions there's equity so that we can target those children who are at greatest risk, and that includes Aboriginal children. I'll show some data on that. I've got a lot of conflicts to declare, so I'll just put it up there. I've advised a lot of companies around RSV, both in Australia and overseas, but I haven't received any personal remuneration, and the views I'll give and my interpretation of the data will be mine and not anyone else's. So this is what I hope to cover today, sort of briefly talk about why we're thinking about RSV in pregnancy for infants, talk about the development of the vaccines and mention the parallel development of monoclonal antibodies, and where we've got to with RSV vaccination, and actually just demonstrate some data that I think shows a remarkable consistency across multiple platforms and age groups of the potential for reducing the burden of RSV disease. So I won't go through all this data. I think there's a couple of take-home messages. 1 in 50 infants will be admitted to hospital for RSV in Australia in the first year of life. They won't die of it. We don't have any specific treatments that have been used in Australia. We have great supportive care globally. There's at least 100,000 children who die each year of RSV because they don't have access to care. Many of them die at home, and they get complications such as bacterial pneumonia. So, if we think about flu that we talk a lot about in children, RSV has a much greater burden of disease. And when we think about who needs protection, it's clear that children under 6 months are those that are at greatest risk, as shown in this. As shown in this figure. In fact, it really starts at about 1 month of age, because there is some maternal antibody that's passively provided to the infants that protects them initially, but after about 4 to 6 weeks, they start to present with RSV and get very unwell. And that continues for the first 5 years of life. And in fact, if you look at all-cause pneumonia in children under 2, RSV is the #1 cause, greater than bacterial pneumonia, pneumococcus, or influenza. And there also is a burden in the elderly, which I'm not going to talk about today. I'll just briefly mention some of the work that's being done in that area. But pregnant women themselves don't actually get a lot of severe RSV disease because they're relatively healthy, but there are case reports of hospitalisations with RSV and even intensive care admissions in pregnant women with RSV. It's generally not tested, so we don't quite know, but it's certainly different to flu in that context. And the other thing I just wanted to point out is that, was that Aboriginal children are at least twice as likely to be admitted to hospital with RSV than non-Aboriginal children. And there's also a tail end to getting infected with RSV in early life. We know that if you're infected with RSV in the first couple of years, you're much more likely to represent with wheezing, and this is some work done by Hannah Moore and the team that was presented at the RSVNet conference earlier this year, demonstrating the ongoing burden due to wheeze. Now, it could be a chicken and egg situation. Children who are more likely to wheeze generally be admitted to hospital with RSV, and that's certainly probably the case for premature infants whose lungs aren't developed properly. But there's also good evidence, and we're hoping some emerging evidence that actually preventing the very early RSV will stop at least some of the longer-term complications, with some evidence for this in things like recurrent otitis media and recurrent lung infections. So it may be that it's a combination of both. Susceptible population who then get more complications when they get early RSV. So this has been a long journey. It's 60 years since the first studies of RSV vaccines occurred, done by some of these gentlemen from the NIH. But in fact, what they found was that children who received their vaccine that was designed like the polio vaccine actually got more disease. And they couldn't quite understand it, but it really stopped RSV development for about 30 years. But the really critical understanding was actually that, like COVID, you have to develop vaccines against the pre-fusion protein, which is the major immunogen, like the spike protein on SARS-CoV-2, because that's how it infects cells. And this sort of rather globular protein is the fusion protein. And when it binds, it actually changes to this sort of more linear shape, so it can actually adhere to the cells and infect them. In fact, the preferential form is that low energy state, so it's like a trigger and it goes off. Now, we didn't know that till 2013 when the structure was finally decoded, and that's meant that since then we've been able to develop effective interventions against RSV, both in terms of vaccines but also monoclonal antibodies, and that's really been pivotal to this battle. So, and a lot of people are trying to develop preventive strategies for RSV. This is a figure that's updated by PATH on a regular basis, and when companies decide no longer to continue the program, they drop off. So it's not all the vaccines that have been ever developed. These are only the ones that are being developed now. And I just wanted to make the point that actually you can see that all the strategies that we've used with COVID vaccines were actually already being used to develop RSV vaccines. And that's one of the reasons why companies such as mRNA vaccine companies and adenoviral vector companies were actually able to produce the vaccine so quickly in the pandemic. So it's been a fantastic ability, understanding that science. They understood the same thing was needed for SARS-CoV-2. So that's one of the reasons why this research has been so important. In a slightly easier form to read, you can see that there are a number of ways that we are looking at RSV vaccines in different populations. So for children, there's a number of different ways that we're looking at it that are being developed. Pregnant women, is that? It looks as though something's come off the. Oops, no. Okay. All right. So pregnant women, only protein-based vaccines have been used, but that's because they have the longest safety profile, as well as already being licensed for things such as pertussis and influenza. And so in 2016, a large efficacy study was started by Novavax, which ultimately proved to be unsuccessful, despite having very high efficacy in low-income countries such as South Africa. They were unable to demonstrate efficacy in the United States, giving a lower estimate of protection in that first 3 months of life. And this related to the fact that in the United States, the participants were getting vaccinated too late, so very close to 36 weeks gestation, so not having enough time to pass the antibody on to the mothers, and also too early in the season. So it was more than 3 months before the season occurred, and so they'd lost most of the protection by the time RSV started to circulate. But they were able to show that it's safe and it is effective if your timing is right, and also showed some of those longer term aspects such as ongoing prevention against recurrent lung infections and otitis media. So this was a very important proof of principle, but Novavax have subsequently dropped this as a program. So the two other companies were pursuing this though, and this is data from Pfizer. So showing here, this is what happens naturally with antibodies in mothers that have been passed to the infant and how quickly they wane. And this dotted line here is the estimated neutralising antibody that's derived from palivizumab that we've been using in very preterm infants for a long period of time that was associated with protection. And so you can see here that in the infants of mothers who'd been vaccinated with the bivalent RSV vaccine, they actually remained above that threshold for the first 6 months of life. So this sort of led to an ongoing efficacy study. And in fact, both GSK and Pfizer were working on vaccines at this time. They're slightly different designs, but unfortunately in the GSK study they found that there was an excess of preterm infants being born in those mothers who had received the vaccine, and they have stopped that program, whereas Pfizer was able to continue the program and has recently published it. And this is the data that was presented at RSVNet over the imbalance that they were seeing, and you can see here that the relative risk was about 1.38, so almost 40% more preterm deliveries in the vaccinated group, and with similar increases over the gestation. So it seemed to be fairly consistent, but it was only seen in low and middle income countries. So not in mothers born in infants born in Australia or the United States or Europe, and they're still trying to work out exactly what the cause of this, but some of these preterm infants died, so that was the reason why they in fact stopped the study. And GSK no longer appears on that map of the vaccines in development, as they have decided not to pursue it. But it does mean that understanding cause of prematurity and whether it's occurring with vaccines will be important for any future maternal RSV vaccines. So this study was published 6 weeks ago. Importantly, it was shown to be safe. So if I just guide you through here, on the left is the mothers who've received the vaccine. On the right is the ones who had placebo, and you can see here there are low levels of local redness and swelling, about almost half the mothers complaining of some pain at the injection site, but actually very few having severe pain, so relatively well tolerated. These are symptoms that pregnant mums get just anyway, so fatigue is in about 40% of pregnant women. It would not be surprising to anyone. But when you look post vaccination, there's really very little differences apart from perhaps muscle pain, which I think probably reflects the injection site pain. But importantly, when we compared to placebo, if there was the degree of adverse events in the mothers or the infants, there was no significant differences. And particularly with this issue of prematurity, you can see here that there's no significant difference. The confidence intervals overlap for prematurity, but it is slightly higher in the mums who received the vaccine. However, so too was SARS-CoV-2 infection. So the hypothesis that I think needs to be explored is whether or not protecting mums against RSV stopped them getting COVID, particularly in low and middle income countries where they didn't have baseline COVID vaccination rates, and then developed, and therefore, because they got COVID, they were more likely to have a preterm delivery. But certainly within this study, when you looked at both maternal and infant complications, there was none seen. Now this is the sort of Kaplan-Meier survival curve. So this is looking at how many people are accumulating how many infants are getting infected over time. This is the placebo, so this is the number of children that you're seeing with RSV, and these are the ones who have received the vaccine. So you can see that particularly for the first 3 months, there's very little getting severe RSV. So these are children breathing very fast, having low oxygen saturations, the sorts of children that will tend to get admitted to hospital. And even for milder infections that mean that they see the GP but don't necessarily get hospitalised, again you see a similar pattern. And importantly, these lines aren't coming together, which means that once the immunity wears off, there's no, as the antibody levels decline, there's no evidence that you're getting rebound. So if we look at efficacy, we can see here that it's almost 60% for any reason to attend a general practitioner, but it's 80% for the more severe cases, some of which were hospitalised. The reason why this is lower is some babies who are just having feeding problems without having severe chest problems get admitted to hospital, particularly if they present early. So they wouldn't qualify for having severe lower respiratory tract infection, but they're still being hospitalised. And this is the 1 in 50, and in this study I think it was 1.8% were getting admitted in the placebo group in those first 6 months. There is some ongoing evidence of persistence of that immunity that goes for 6 months, but really not a lot of additional protection beyond 6 months, which would be in keeping with the antibody data. Importantly, if you look at all RSV infections requiring attendance at the doctor, you also have moderate efficacy here. So this is certainly reassuring, and it suggests that there probably is some mild protection against upper respiratory infections, which would include things such as otitis media. And this might be really important in terms of the overall cost benefit of prevention of RSV in early life. This has been submitted for licensure around the world. The initial considerations by the FDA are very positive, so we're hoping that this will be a vaccine that will be available. And I think one of the good things is that the Gates have agreed that they will contribute to funding to ensure this vaccine can be made available for low and middle income countries around the world. So this is just a summary. The first maternal RSV vaccine to be licensed has been demonstrated to be safe, to be effective for up to 6 months, may have additional benefits through breastfeeding, although they remain to be seen. But probably the biggest issue for implementation is that you need to be able to time it so that you're vaccinating those mums whose infants are going to be born immediately before the RSV season. So the question is, can we afford to vaccinate every pregnant mum, even if those that are being born just at the end of the RSV season may not benefit? And I guess the other option, of course, people will be aware, there is a monoclonal antibody that also has shown similar levels of effectiveness, and certainly can complement a maternal vaccination in terms of groups such as preterm infants or those whose mothers haven't been vaccinated, but it may be easier to implement in a seasonal manner. But will parents be happy to have a immunisation with a monoclonal antibody for their babies rather than a vaccine for themselves? And I think the data that's being done that's looking at this would suggest they don't mind as long as it protects their babies. And this is some data just from a large, it's not yet published, was presented at ESPID, showing, again, very high levels of efficacy. This time the outcome that I'm showing here is hospitalisation. So 80% for the monoclonal antibody given immediately before the RSV season, so significant impact, and represents about 58% of all those hospitalisations that are occurring during that RSV season, the protection. So that's any child presenting with a low respiratory infection such as bronchiolitis or pneumonia. So certainly very promising, I think, from our point of view. So we've two effective interventions. Adults also, especially older adults, also get RSV. And I'm not going to go through this data. I just wanted to show the endpoints for these sort of 4 different vaccines, 2 protein vaccines, an mRNA vaccine and an adenoviral vector vaccine, remarkably similar endpoints in terms of efficacy between 60 to 80% across the board, depending on the severity. Unfortunately, these studies haven't been able to look at hospitalisation, as there's not quite enough adults being hospitalised in these studies that occurred during the pandemic. So just in summary, I think RSV is a disease that can be controlled with the new technologies that we are developing. There is certainly evidence that it's safe, that we can protect infants with passive antibody transfer or with monoclonal antibodies. And in all of the studies, there's been no evidence that, unlike those poor orphans who are in those early studies with inactivated RSV vaccines, they don't get more severe disease in the second year of life. There are differences between the interventions that may determine who uses them where. And one of the issues for monoclonal antibodies, for instance, is that it's not considered a vaccine, so it isn't on the national program. And I would just like to acknowledge the people who have helped put this work together and done the trials that we've been involved with. So happy to take any questions. Thank you.
Thank you, Peter. The fan base will be very pleased. Thank you. So a question I've got to start with online, is there a blood test antibody surrogate of protection?
So the surrogate of protection was that sort of dotted line that I showed on that graph for infants going forward. We don't know whether that equates for older adults, for instance, or for older infants, and this in theory may do, but there may be other aspects of immunity that will alter that in other age groups. So that's really looking at infants who don't have any antibody. That level of antibody does seem to be protective.
But it wouldn't be used clinically, or would you use it clinically?
No, it would not have utility clinically. I don't think Ian Barr's lab could have managed all the tests that would be requested. But there are assays where you can measure whether somebody has been exposed, who we would think would not necessarily need it in older children. But I don't think so. I think no program works well when you're trying to measure antibodies to see whether they need it. But that may be different in older age groups.
Is it going to be a yearly vaccine?
Sorry?
Does it have to be given every year?
That's a great question. We don't know that answer. So there are the adult vaccines. They look as though they do probably prevent disease for more than 1 year. There's some emerging evidence that supports that. In pregnant mums, they generally get pregnant every 2 to 3 or 4 years. So I think it would be likely to be like pertussis. We'll recommend it every pregnancy, but that's still to be determined. And that might impact on cost effectiveness, because you might have enough antibody. You might be between those standard natural immunity mums and the vaccinated ones. So that may not be necessary. We don't know.
And another question on no, hang on, it's just not printing up. No, any other? You mentioned FDA approved a vaccine in the US. Are they going to get it their winter? And we'll wait for our winter. Yeah.
Yes, that's great questions. So we don't know. So it's a bit complicated, but the FDA have a committee that meet who decide whether or not the vaccine should be licensed for that particular age group, and their equivalent of a TARGI are needed to recommend it before it will be given as a program. So I think that's what they're trying to do. As I said, there's also monoclonal antibodies that may also be licensed in that process. So I think, and I can't comment for the TGA, I would hope they would take a approach that if there are useful interventions, they will license them when they'll be most useful, i.e. before the RSV season, but we can't predict that. And, some people may say we need more safety data. That was
the next question. Is there, just before is there a European submission or some work going on? So is Europe making it? And secondly, do you think the CDC will manage to monitor the vaccine safety of this, seeing as we've got one report showing increased infection and miscarriage? Like, is our vaccine safety hang up to it, and are we going to get a CDC that manages that for us?
Yes, well, actually, as I think most people know who I've talked to, that I definitely think the CDC should be managing vaccine safety, so that's a yes. I think in Australia we have great safety surveillance systems to pick up these sorts of issues, but I think for prematurity you'd probably have to have a specific one to demonstrate that. What was the other?
European.
Europeans, yeah. So the study that I showed, that was a study of 8,000 babies in Europe, of whom 4,000 got the vaccine. But there are programs that are being rolled out in a number of countries for the monoclonal antibody, not for the maternal vaccine. That hasn't been used anywhere.
So not.
So we don't have more data yet, but those countries will do safety surveillance as they've done for COVID.
I think Ian Barr wants to ask for more money so he can do more testing. So, last question.
I'll send you my bank account details. Peter, are we going to have a bit of a travel vaccination warning for this maternal vaccine? WA is currently experiencing low RSV. The East Coast is raging. Northern Hemisphere seasonality is very tight. So you're going to have a travel warning in there as well. It's a very logistic nightmare you've got.
So I'm not sure how many pregnant mums would be travelling, but I do think people who want to avail themselves of licensed products that will reduce their risk when travel, COVID, for instance, I think that's a big driver for a lot of people, is when they're travelling that they get a COVID booster rather than I just want to protect myself for the winter. But I think like flu, if you're travelling during the flu season, you should consider getting a booster if it's appropriate. And it's been a long time since you've had your last flu vaccine. These vaccines look a bit better than the flu vaccines, I would say, in terms of the duration of impact. So I would hope that people will be having it for their Australian RSV season rather than thinking about it as a travel vaccine. But I think they're all the sorts of things we don't know. I mean, it is important to just recognise, I didn't really highlight it, but These vaccines have gone from phase 1 to phase 3 efficacy studies and licensure within 5 years. So, and that's a direct impact of COVID and our approach to rapidly look at how we can get these vaccines licensed as soon as we can, which I think is great. So I think that is certainly a benefit that we have, but it means we don't have that longer term duration. But that's work we can do on the run, and I think Australia is very well placed. RSV is notifiable. We're getting a better handle on exactly how much disease it causes, and I'll leave it there.